Good morning, everyone, and welcome to today's webinar, Genetic Testing Before Implantation, Be Proactive, Not Reactive. Before we get started, I would like to go over a few quick items about today's event. First, all physicians in attendance today will receive an AMA PRA Category 1 credit, and all other providers will receive a certificate of completion for 1 contact hour credit. The certificate will be emailed to you by Harvard around midsummer. Now, without further ado, I would like to introduce today's speaker. Dr. George Kovalevsky is a board-certified reproductive endocrinologist at Delaware Institute for Reproductive Medicine in Delaware. Dr. Kovalevsky was born in the Ukraine and came to the United States as a child. He completed his undergraduate studies at Brown University in Rhode Island. He then received his medical degree from the University of Rochester School of Medicine in New York. Next, he trained in obstetrics and gynecology at the Ohio State University in Columbus. Finally, he completed a fellowship in reproductive endocrinology and infertility at the University of Pennsylvania in Philadelphia. Here, he also received training in clinical epidemiology and biostatistics. Over the years, in addition to his clinical work, he has continued to conduct research and teach medical students and residents. Dr. Kovalevsky specializes in all areas of reproductive medicine, including assisted reproductive technologies and operative hysteroscopy. We encourage you to submit questions to Dr. Kovalevsky using the questions section of the control panel. You may send in your questions at any time during the presentation. We will collect these and address them during the questions and answer session at the end of today's presentation. All right, we're going to get started. I'm going to pass it over to Dr. Kovalevsky.
Hello, I'm glad you could join us today. My topic for today's lecture is going to be genetics and testing before implantation. Genetics is such an important area in everything that we do in all areas of medicine, and no less so for reproduction, but in fact I would say more so. Genetics is part of everything that we do, and therefore I want to spend the next 45 minutes or so going into some of the issues that are most relevant for obstetricians and gynecologists. I have nothing to disclose on the financial front, and my objectives for the lecture are to review the benefits of preconception carrier screening and talk about what that offers, talk about the types of preimplantation genetic testing and how it's performed. We'll discuss which patients can benefit from a specific technique of PGT-M, discuss the pros and cons of PGT-A, and understand the controversies involved, and also touch upon implications for pregnant women who conceived after using PGT, as well as address some of the possible directions for the future. So first, to get our language, our nomenclature straight, we refer to testing of embryos as preimplantation genetic testing, and there are several flavors of that. PGT-M stands for Preimplantation Genetic Testing for Monogenic Disorders, and was in the past called PGD. We have PGT-SR, which is testing for structural rearrangements, and then PGT-A, previously referred to as PGT-S, which is testing for aneuploidy. So just to get your minds working, I'm going to ask you a question and challenge you to think. You don't have to respond except for to yourself, so there's no grading involved. The question is which patients could potentially benefit from PGT-M, and there are some scenarios. Is it a woman planning pregnancy whose father was diagnosed with Alzheimer's disease in his 40s? A woman planning pregnancy who has a BRCA1 mutation? A couple planning pregnancy who are both carriers for cystic fibrosis? A woman planning pregnancy whose father died of Huntington's disease, but who does not want to know if she has the problem gene, or is it all of the above? All right, so first let's turn to PGT, preimplantation genetic testing. How is it performed? We have to start by doing in vitro fertilization, IVF. So ovaries are stimulated, eggs grow, and eggs are retrieved. The eggs are combined with sperm in the laboratory, and the fertilized zygotes grow for several days until they reach the blastocyst stage of development, around days 5 or 6 of embryo development, at which point a trophectoderm biopsy is performed and that's the image you see there. Several cells, usually 5, 6, or 7 cells, are removed from the trophectoderm. And that's important that it's a trophectoderm biopsy because the inner cell mass is not affected. So there's potentially less damage to the future child. And it's also important in terms of interpretation. We're not sampling the entire embryo, but we're sampling just the trophectoderm. After the biopsy is performed, the embryos are usually cryopreserved, and the genetic analysis is performed on those biopsied cells. There are multiple techniques that have been used to perform the analysis and still are used around the world. Currently, next generation sequencing has become the dominant technique for a number of reasons. As we focus on this technique specifically, it is a way of massively parallel sequencing. There are a number of platforms that are available for doing so. But in the process, millions of fragments of DNA are created and then sequenced. Computer analysis is then applied to piece together the genome and mapping it to a reference genome. This does appear to give us the best results in terms of highest sensitivity, with better detection of mosaicism, as well as segmental aneuploidies. Some comparisons have showed improved ongoing pregnancy rates and also faster results. Potentially costs can be reduced. Some commercial laboratories are combining elements of NGS with SNP arrays to get additional benefits, such as fingerprinting of embryos and paternal origin of aneuploidy that can then be discovered. If we look specifically at PGT-M, the monogenic testing, we can say that this is a well-proven and well-established technique that is highly accurate. It is used for detecting single gene disorders. And this includes autosomal recessive or dominant or X-linked disorders. Initially, when the technique was first developed, it was applied to severe conditions with onset at birth or soon thereafter. So the most common examples were cystic fibrosis, Fragile X, or spinal muscular atrophy. However, since the inception, the applications have greatly increased, and we now can utilize PGT-M for severe adult onset conditions, such as Huntington disease or early onset Alzheimer's. Also, less serious, or perhaps conditions with lower penetrance that are adult onset, can also be tested for. A couple examples of that would be the BRCA mutation or familial polyposis. Preconception, family history, and carrier screening becomes even more important when you understand the large usability of PGT-M. Because if we can identify individuals and couples at risk, we can prevent having offspring with that disease. So definitely a very powerful tool, but in order for that tool to be utilized, it needs the individuals at risk need to be identified. So that brings us to genetic carrier screening. Genetic testing performed on asymptomatic individuals to determine whether the individual is a carrier of the mutation or the abnormal allele is present. And if you remember our Punnett squares, if it's an autosomal recessive condition, as in the square on the left, we can see that if two individuals with the big R having the mutation have offspring together, 1 in 4 chance, 25%, of having a child with that disease. For X-linked conditions, it's a much more complicated scenario, but if we simplify, we know that if a boy is the result, then the child will be affected with the disorder, whereas the daughter, if she inherits the mutation, will be a carrier. The chance of finding a carrier is impacted by the prevalence of the condition in the population. So carrier screening can be done certainly at any time, including during pregnancy, but as the title of my talk implies, the best time to do it is before pregnancy so that PGT-M can be offered. Partners can be screened sequentially or concurrently. So certainly if time is short, as in during pregnancy, concurrent strategies are potentially more helpful because it takes time, a couple of weeks or so, to get results, and having the results in a timely fashion can make a big difference for counseling the individual or couple. If both partners are carriers of the same condition, then genetic counseling should be offered, and individuals should be counseled to also inform their family members if found to be carriers, because we cannot disclose the information to their family members without the patient's permission. It's also important to counsel the individuals that screening does not eliminate all risk. The testing is not perfect, so there's a residual risk, and it does not replace newborn screening. And lastly, all carrier testing is optional, and it is up to the individual whether they want to have that testing done or not. If we choose to do screening, the next question then becomes, what carrier testing should we do? For which conditions should we screen? Initially, in 2005, ACOG's first recommendation was to test for cystic fibrosis, and that was the first condition as the one that is the most prevalent in the United States. Also, hemoglobinopathies were recommended to be screened for, sickle cell, beta thalassemia, alpha thalassemia, but the screening was mostly recommended on an ethnic-specific basis in populations thought to be at higher risk. 2017, ACOG added the recommendation of SMA screening, and then most recently, ACOG has expanded the recommendations, saying that either ethnic-specific or panethnic or expanded screening are all acceptable, and each provider or practice should establish a standard for their individual practice, their standard approach. All individuals should be offered cystic fibrosis and SMA in at-risk populations, a complete blood count, and a hemoglobin electrophoresis. And then Fragile X screening is recommended for women with a suggestive family history or ovarian insufficiency. In discussing expanded carrier screening, there's been an evolution in thinking as we have realized that our population is largely mixed and made up of individuals with multiple ethnic backgrounds. So while previously the focus was mainly on ethnic-specific panels, we've drifted more towards larger panels that are not ethnic-specific and expanded. Technology has also improved, so we are now able to screen for many conditions simultaneously without increasing the cost significantly. Expanded screening offers large panels and has largely thus replaced the other types that were previously utilized. In designing an expanded panel, still the question remains, which conditions to include and which not. ACOG has made recommendations that a condition whose frequency is greater than 1 in 100, meaning disease incidence 1 in 40,000, well-defined phenotype, and a condition that has significant detrimental effect on the quality of life, cause cognitive or physical impairment, requires surgical or medical intervention, or have onset early in life. So here, there's still a lot of room for interpretation because words like detrimental effect and quality of life can be subjective. And that really leaves a lot of room for individuals to determine what condition they would consider to qualify. So while most would agree that diseases like cystic fibrosis clearly fits that description, others may argue that color blindness may or may not be an example. Can be diagnosed prenatally and allow for antenatal intervention. The other body that has made similar recommendations, the American College for Medical Genetics, also has issued recommendations more recently in 2021. They proposed adopting a tiered definition for carrier screening, and suggested that it should not be ethnic or population-based. They recommend that the screening be more inclusive of all individuals. They suggest that all pregnant patients and those planning pregnancy should be offered tiered 3 screening, where the carrier frequency is equal to or above 1 in 200 in any ethnic group with reasonable representation within the country. In applying that definition, they selected 113 conditions that they thought would qualify to be included in such a panel. Multiple labs that do carrier testing have designed various panels that any practice or individual provider can choose, or they can try to utilize the recommendations from either one of these organizations. Tier 4 screening is offered usually for individuals at higher risk, such as consanguineous couples, or when a particular family history or individual medical history is suggested. So when choosing expanded screening, we have to consider the pros versus the cons. On the pro side, the goal is to prevent a child with that disease, and so we may want to cast a bigger net to try to prevent every single child with such a disorder. On the other hand, the bigger net we cast, the more cost is involved and potentially unnecessary additional testing. Plus, if not adequately counseled, there may be significant anxiety, and counseling itself takes time and cost. So again, my recommendation is to be always proactive in choosing the type of panel that your practice or you as an individual provider feel comfortable with, and then using that as the standard and counseling each one of your patients about the possibility of this testing prior to pregnancy whenever possible. With that in mind, let's shift gears to the topic of preimplantation genetic testing for aneuploidy. This is a topic that has remained a very controversial topic in the field of fertility care, and remains probably the single hottest topic at the annual meetings for the American Society for Reproductive Medicine. Despite its controversy, the use of PGT-A continues to be highly prevalent, with nearly 40% of cycles utilizing PGT-A for when IVF is done. PGT-A allows for comprehensive chromosome screening of the embryos. The value indications for this remain controversial. We have to be cautious because our history has taught us that if applied prematurely, techniques may cause harm, and this was not an exception for PGT-A when previous ways of performing it on day 3 blastomere biopsies were found to be inaccurate and not helpful, but rather potentially harmful to embryos, and did not improve success rates, but rather lowered them. We still have limited data regarding the usefulness of PGT-A and its safety, and hence the controversy continues. Why is PGT-A important at all? Well, it reflects the problem of aneuploidy in our gametes and in embryos. We know that many of the embryos, in fact, most of the embryos produced, are aneuploid. As the graph that you're looking at demonstrates, at the age of 38, approximately 50% of blastocysts achieved are found to be aneuploid, and the percentage greatly increases with the individual's age after that. If an aneuploid embryo is transferred into a woman's uterus, most of the time a pregnancy will not result. If a pregnancy does result, the vast majority of those pregnancies will end up as a pregnancy lost, mostly early in the first trimester. And then for the small fraction of the pregnancies that do continue, those will usually be the pregnancies with aneuploid offspring, such as Down syndrome. PGT-A has been shown to have several significant benefits. The first and most important is that it results in higher implantation rate. And so that has been pretty clearly demonstrated in multiple studies. And this one meta-analysis demonstrates that it is clear if you take an embryo that has been tested and found to be euploid and transfer that and compare it with an untested embryo, the pregnancy rates will be higher, implantation rates will be higher. That's now is no longer debatable. Second, the benefit of reducing multiple gestation rate. And this is kind of self-evident and intuitively obvious, but nevertheless, it was good that it was demonstrated in a study where embryos were transferred one at a time if they were found to be euploid versus 2 untested embryos. We saw that clinical pregnancy rates were slightly higher in the arm with the 2 untested embryos, but because of higher miscarriage rate, the ongoing pregnancy rate was similar. While looking at the multiple gestation rate, clearly there was a huge difference with transferring more than 1 embryo, resulting in a much higher rate of twins and even some triplets in this particular study. The third benefit is the benefit of saving cost and time for individuals who are using PGT-A. In one analysis that was performed, it was shown that by doing PGT-A, it greatly reduced the cost and the time because of repeat failure transfers and higher rate of pregnancy loss in individuals with who did not utilize PGT-A. It appears that if you have multiple embryos, obviously the cost efficacy is going to be higher rather than if you have fewer. And in this study, they showed that the cost was lower when using the PGT-A if at least 2 embryos were achieved. On this other side, there are a number of criticisms of PGT-A that have been voiced over the years. The first and perhaps most significant is that there's the potential of wasting normal embryos. It has been suggested that there may be a higher false positive rate than previously stated, and some reports have estimated the false positive rate to be as high as 40%. We're going to come back to this discussion because I believe a lot of this has to do with the concept of Mosaicism, and we have gotten a lot more educated and we've learned a lot more about the implications of Mosaicism and can potentially reduce and address this criticism to a large degree. Secondly, PGT-A does not improve the cumulative success rate. That is also pretty self-evident because if an IVF cycle is performed and several embryos are created, let's say 5 blastocysts are achieved, and let's say 2 of them are euploid and 3 are aneuploid. Whether you do PGT-A or not, you're always going to end up with having 2 euploid embryos. And eventually you're going to transfer one of those embryos and have a reasonable chance of success. So we can't fix the aneuploid embryos, and therefore the cumulative pregnancy rate cannot possibly improve from the total IVF cycle. All we can do is change the path that leads to the highest success rate by identifying the embryos with the highest potential and not using embryos that may result in wasted transfers and miscarriage risk. The other concern is that women who are most likely to have aneuploid embryos are also the ones who are more likely to have no euploid embryos to transfer at all. And therefore, the argument would be that PGT-A will not improve the success rate if there are no embryos to work with. Lastly, there's concern about safety of PGT-A because we still have very limited data proving that it is indeed of no risk to the embryos or to the children born from embryos that were tested. Only one study that I've identified has found that no effect on reproductive potential of the embryo, but we have very little data on the long-term follow-up of children, although to date there's been no study showing any significant concern. Several studies have caught attention in the press and have attracted a lot of attention in the field. The study that was widely discussed, was published in 2019 and referred to as the STAR trial. Here, it was a multi-center randomized clinical trial where 661 women between the ages of 25 and 40 were found to be of good prognosis, meaning that they had at least 2 blastocysts, were randomized to either a single frozen embryo transfer of or a single blastocyst transfer by PGT-A versus selected by morphology, the conventional approach. The results were not what people expected at the time, and there was not a benefit seen at all age groups. However, in the older population, ages 35 to 40, is where a benefit was appreciated. It is notable that in the study, there was a very high amount of heterogeneity among centers, and some centers had much higher aneuploidy rates than others. So that started to raise concerns as to why that was, and that's another topic that led us down the mosaic discussion. And also in the study, 25 patients in the PGT-A group were found to have mosaic embryos and did not have an embryo to transfer. And if the study were done today and those embryos, mosaic embryos transferred, perhaps the results would be significantly different. Another study that also captured our attention was published in 2021 in New England Journal. And here, this was a multi-center non-inferiority trial conducted in China. A large number of women, over 1,000, with infertility and also good prognosis. In this study defined as women ages 20 to 37 with 3 or more good quality blastocysts, were randomized to either PGT-A or conventional IVF. Here, going into the study, I would not have expected there to be a significant difference because of the point that I made earlier about the cumulative success rates. If you already know that you're going to be transferring up to 3 embryos, it's going to be hard for PGT-A to demonstrate any benefit whatsoever. And indeed, the cumulative live birth rates calculated after up to 3 single frozen embryo transfers were not better in the PGT-A arm. In fact, in the younger population, it appeared to be lower. The cumulative clinical pregnancy rate was the loss rate, however, was found to be significantly lower in the PGT-A arm. So a lower miscarriage rate as expected in the PGT-A arm. So here it's a little bit challenging then to reconcile how we've clearly demonstrated that PGT-A improves implantation rates, but does not always improve success rates. And one of the main complexities of PGT-A is the concept of mosaicism. Mosaicism being the presence of more than one cell line within an embryo. And the most common scenario we think of where there may be aneuploid cells present both in the trophectoderm and in the inner cell mass. But there are different types of mosaicism where sometimes mosaicism may be exclusively found in the inner cell mass, whereas other times exclusively in the trophectoderm. Trophectoderm biopsies have been well correlated when the test result shows that the embryo is euploid or aneuploid. However, there's less concordance in the setting of mosaicism. Next generation sequencing allowed us to have a much higher detection rate of mosaicism. And the prevalence of mosaicism has been reported to be over a significantly differing range, where some techniques demonstrating as low as 3%, while others demonstrating over 20%. This has led some to speculate that perhaps mosaicism is being overcalled by some labs and maybe nothing more than noise or lab error. Perhaps it's due to the techniques used to perform the biopsy itself. Other theories include that mosaic embryos may self-correct and still result in normal birth. And you can imagine a scenario where, for example, the embryo here in the picture has several cells that are aneuploid, but the aneuploid cells are not as healthy, perhaps, as the euploid cells. And as the embryo continues to grow and divide, the aneuploid cell line may work itself out because their reproduction rate will be much less efficient, perhaps, than the healthier cells. So hence the theory of self-correction, where the embryo will continue to grow and divide if it has a substantial amount of healthy euploid cells, and the embryo may still be successful. With those theories in mind and the results of studies suggesting that there are significant false positive rates and embryos are being wasted, investigators started to look at the possibility of transferring mosaic embryos, and the first significant publication in 2017 indeed showed that when mosaic embryos were used, there were still positive pregnancies and healthy children being born. They did find that there were lower implantation rates in this study, 53 versus 70%, but still a very respectable implantation rate overall. There was also a higher miscarriage rate, 25 versus 10%. They further suggested that there are different types of mosaicism, and depending on the type, the outcome may be more predicted. So the more complex mosaics had much lower pregnancy rates, whereas in mosaics that were low-level mosaics, we had the best pregnancy rates. Also, there was a significant concern that if we did use the mosaic embryos, is there any added risk to the babies that were the result? And that remains uncertain, although to this date, we still have no significant reports saying that there is an increased incidence. This led, over the last several years, several labs and investigators to look at their results transferring mosaic embryos. And a little over a year ago, Viati et al. Published an analysis of 1,000 mosaic blastocysts. And this really helped us draw some important conclusions. So first of all, when they looked at euploid embryos versus mosaic embryos overall, they saw that the implantation rate was indeed somewhat lower, but still a pretty good implantation rate, relatively speaking, 57% versus 46%. Similarly, ongoing pregnancy rates were lower because of increased miscarriage rates, 52 versus 37%. Again, this is all mosaic embryos without differentiation. When they further broke out the mosaic embryos with whole chromosome mosaicism, these results were worse in that particular subgroup. When the results were segregated by the level of type of mosaicism, we also saw some very helpful observations. This study defined low-level mosaicism as having less than 50% mosaic cells, aneuploid cells, and when low-level were compared with the high-level, we saw that there was a significant difference, 48% versus 39% for implantation, and 40 versus 28% for ongoing pregnancy rate. When we specifically then broke it down to the whole chromosome mosaics, again, the low-level did much better than the high-level in both the implantation rate and the ongoing pregnancy rate. When looking at segmental aneuploidies, it appeared that there was no difference in terms of low-level versus high-level, and overall, the implantation and ongoing pregnancy rates were quite high. These results also make me think that it is not just lab error that leads to high mosaic rate of embryos being classified as such. It appears that if that was simply a lab error or overcalling due to noise, you would not have significant differences between these embryos as we're showing here. So now we have multiple studies demonstrating that mosaic embryos can result in healthy pregnancies and children. And overall, mosaic embryos appear to demonstrate lower pregnancy rate and higher miscarriage rates. Miscarriages, when they do occur, tend to occur early, before 8 weeks of gestation. And then when Viati data is analyzed, we can see that we can order embryos for transfer based on that data available. So if a euploid embryo is available, certainly that is going to be the embryo that we should start with. If only mosaic embryos, we should start with the segmental ones, then go to the low-level mosaics, 1 chromosome, 2 chromosome, and then towards the complex and high-level mosaicism. So this is really useful for helping counsel patients and selecting embryos for transfer and not discarding all mosaic embryos. PGT-A has also been useful for recurrent pregnancy loss scenarios. Most studies do show that there is a reduced pregnancy loss rate after use of PGT-A embryos, particularly in older women. But only one study has looked specifically at the recurrent pregnancy loss population, and the results were difficult to interpret. The miscarriage rate was much lower in the population that had completed PGT-A and had euploid embryos. However, the intent to treat analysis did not find a difference for several reasons, including that there was changing of arms during the study, number of cycles were canceled, and the number of patients, significant number, did not have any euploid embryos to transfer. So currently, the ASRM guidelines still state that routine preimplantation embryo testing is not justified. However, in practice, PGT-A is routinely used for unexplained recurrent pregnancy loss. And that leaves us with somewhat of a dilemma as to the usefulness of PGT-A. ASRM continues to state that there is insufficient evidence to recommend routine use of PGT-A and suggests that the technique be individualized on the basis of age, cost, and personal preference. Another study published in 2019 tried to answer that question as to for whom PGT-A is useful, and they did show that for younger women, as we would suspect, it is not nearly as helpful as for older women, for whom here for over 38, PGT-A showed a much higher implantation rate and live birth rate. So it appears that there may be a target zone of a population for whom PGT-A is most useful. And the factors that are the determinants of this are, number one, aneuploidy rate. And we know that this is greatly related to age. So as women get above the age of 35, the pregnancy rates, the aneuploidy rates continue to rise. So for them, PGT-A may be very helpful in identifying the embryos that are useful. However, we know that with increasing age, the chance of not having an embryo to transfer also increases rapidly. So those are the two curves that we have to balance, and hopefully we can identify a zone where we can find individuals who still have enough embryos to test to be useful, and for whom PGT-A can make a significant difference. And that would be our sweet spot. Now, those results did not consider mosaicism, and these studies all were done prior to utilization of mosaic embryos. And I'm optimistic that if we apply the most recent knowledge and utilize the low-level mosaic embryos in particular, we can increase the size of the sweet spot and help more individuals with PGT-A. So that's where we are at this point. There are a number of techniques in development, a couple of which I want to highlight for you. One of them is non-invasive PGT-A. So this is the technique where the culture media in which the embryos are grown and then is normally discarded can be used for analysis for cell-free DNA testing. There are obvious advantages. There's no risk of harm to the embryo since the embryo is not touched at all. It will cost less and require less skill to do the testing since no biopsy is being performed. The data so far shows a pretty high concordance of results with traditional invasive PGT-A, with several studies showing results to be over 80% concordant. However, that may not yet be good enough, and currently the technique is utilized largely for prioritizing embryos rather than selecting embryos for transfer or to be discarded. Hopefully, as our testing improves and our understanding of how to test the media better, perhaps this can replace the invasive PGT-A completely. Another area that has captured a lot of attention is the concept of polygenic testing, so PGT-P. The goal here is to estimate the risk of developing specific polygenic disorders. And the list of these disorders includes several types of cancer, diabetes, coronary artery disease, and schizophrenia. In doing this testing, the embryo is first tested with PGT-A, and if the embryo is euploid, then a health score is calculated for the embryo based on the number of genes that are analyzed. And then the health score can help determine which embryos to transfer first. So it is simply a technique for prioritization of embryos based on their risk of developing these conditions later in life. And as you can imagine, this technique is highly controversial, and ethical concerns have been raised as well, alongside concerns about the clinical accuracy of predicting individuals with these conditions. So the last question that I want to address is how to counsel individuals who have used PGT-A and are now pregnant, as many obstetricians are facing in their daily practice. So in a scenario where a 39-year-old with her first pregnancy at 10 weeks gestation conceives with IVF using PGT-A, what testing should be offered for her in terms of screening for aneuploidy? And the recommendation currently should probably be that all of the techniques that you currently utilize in your practice should be made available just like you would for individual without PGT-A testing, because PGT-A is a screening test and not 100% accurate. There are arguments that CVS perhaps is not the best strategy, since the embryo was already tested using trifecta-DIRM testing, and that's what CVS would do as well, testing the placenta, and amniocentesis may be a better test. But nevertheless, CVS is an option to be considered as well. The question I posed to you at the beginning of the talk regarding which of these clinical settings PGT-M may be useful, the answer here is all of the above, as I've alluded to throughout the first half of the talk, as all of these could potentially benefit from use of PGT-M. So in conclusion, I hope I've shown you that PGT-M is a highly accurate and effective modality for prevention of having a child with a monogenic disorder. And therefore, prior to conception, obtaining family history and offering expanded carrier screening can be extremely helpful in identifying individuals in risk and allowing them to decide whether PGT-M should be used. On the second half of the talk, we focused on PGT-A, and I pointed out that it is still controversial, but appears to be very effective at improving implantation and pregnancy rates, and therefore, on an individual basis, can make a big difference in a particular population of individuals at risk for having children with aneuploidy, with the caveat that they need to have enough blastocysts to work with. Also, has been suggested that it is very useful for reducing miscarriage rates. And lastly, we focused on mosaicism as a complexity for PGT-A, but we have learned so much about mosaicism in the last 5 years, and we'll continue to learn more and continue, I think, to improve our ability to offer PGT-A as a really helpful technique for many individuals. With that, I'll stop here and love to hear any questions.
Thank you, Dr. Kovalevsky. We are now going to begin answering questions submitted during today's presentation. As a reminder, you can still submit questions through the questions panel in your attendee control panel. Dr. Kovalevsky, our first question is, I have noticed some practices that do PGT-A on almost all of their patients. Is this something you recommend?
So it's true, PGT-A use is very widespread, and nearly half of cycles are using PGT-A, and some practices are applying it universally. I don't think that that is perhaps the best approach, and I think more of an individualized discussion with your patients is perhaps better, because for some individuals, spending the money on PGT-A may be better used, the money may be used better for other techniques and other options. So therefore, I think the simple answer is that it's probably not the best approach to test everyone with PGT-A, and I would reserve it particularly to individuals at higher risk, so mainly older, and especially if they have several embryos to work with.
Thank you. Our next question is, when do you recommend to do, like which panel do you recommend for expanded carrier screening? They were saying basically there's a lot out there and they're wondering which size panel to choose from.
Yeah, so this is a very highly individual decision. And what I do may not be the right panel for your practice. So it depends on your population and how you counsel your patients. So I do think that any type of an expanded panel is generally a good option, and most commercial labs have varying size panels. Some people like to have the biggest panel possible to get the most information, knowing that that will come with a higher rate of anxiety, because most individuals will be identified with having a condition that they're a carrier for. On the other hand, the bigger net, the better the chance of identifying a condition and a child at risk. There's also arguments what conditions, if you have the largest panels, are some of those conditions not conditions that you even want to screen for? Is it worth screening for those conditions? So in general, if you want to be on the conservative side, then I would recommend going with the ACGM guidelines and the conditions that they have selected. And most of the commercial carriers have a panel that usually either uses exactly those guidelines or has a panel that closely mimics those guidelines.
Thank you, Dr. Kovalevsky. That was our last question. And thank you, everyone, for attending today's webinar, Genetic Testing Before Implantation, Be Proactive, Not Reactive. If you have any other questions, you can contact myself, Alyssa Cooper, at ecooper@bostonivf.com. Once you leave today's webinar, you'll receive a survey on the presentation, and we would appreciate it if you could complete the survey and provide your feedback to help with future educational webinars. You will also receive a follow-up email within 24 to 48 hours with a link to view a recording of today's webinar. On behalf of Boston IVF, Delaware Institute for Reproductive Medicine, and Dr. Kovalevsky, thank you for joining us and enjoy the rest of your day. Thank you, Dr. Kovalevsky.
Thank you.